what I want to talk about now is pharmacokinetics. Now, earlier today I mentioned that kinetic means movement, kinesis. Pharmaco means drug. So it is the movement of the drug through the body. And we divide pharmacokinetics into 4 parts. In fact, look on page B2. Page B2, right in the middle. Absorption, distribution, metabolism, and excretion. These are the 4 phases that are collectively called pharmacokinetics. How is the drug moving through your body? From the point where it's absorbed, how it's distributed throughout your body, how it's metabolized or broken down, and finally how it's excreted or eliminated from the body. So I first want to talk about absorption. The absorption of the drug. And usually when we're talking about absorption of most drugs, what we mean is absorption into the bloodstream. Most drugs, we want them to work systemically, meaning throughout the body. That's not always the case. Some drugs, we want them to work topically. But it needs to be usually absorbed into the body, into the bloodstream. So what do we mean by absorption? I want to remind you that we are made up of cells. It's always hard for us to grasp that. It's hard for me to grasp it. We're made up of about 60 trillion cells. And how many classes in the past did you see a picture of a cell membrane? Remember that? Whether it was biology, anatomy, microbiology, physiology. They always went back and reminded you what a cell membrane is. So when we talk about absorption, the drugs have to be absorbed across membranes. And when we say membranes, we mean cell membranes. There are cells making up the wall of blood vessels, right? So the drug has to be absorbed across these membranes. It has to be absorbed across the membranes or cell membranes of our skin, wherever it is. Now, so we want to remind you that the cell membrane of every cell is largely made up of phospholipids. Remember that? A phospholipid bilayer. A double layer of phospholipids. And phospholipids, remind you, are commonly represented, drawn like this. This is commonly the way a phospholipid is depicted. And you might kind of somewhat recall that a phospholipid molecule is kind of schizophrenic. This part here is hydrophilic, which is the phosphate part, but these 2 strings, as it were, to me this always looks like a balloon with 2 strings. The 2 strings are fatty acids. These are fatty acids. And fats are hydrophobic. They are hydrophobic. They hate water. Now, another way of saying this, I could say they're either hate water, or I could say they are lipophilic. They like fats. So this part of the phospholipid is hydrophobic. It hates water. It likes fats. You'll notice that when we look at a cell membrane, the part of the double layer of phospholipids, the part that likes water, is either facing the cytoplasmic fluid on the inside of the cell, the cytoplasmic fluid or water, or it's facing the tissue fluid on the outside, the tissue fluid or water on the outside of the cell. But the middle of the cell membrane is a double layer of fats, fatty acids. So this whole middle area hates water. I always thought that this reminded me of an Oreo cookie. You know, if you have like 2 cookies, here's a cookie, and this is the creamy filling in the middle, like an Oreo cookie. This is all creamy filling. This is all fat. So you're immediately thinking, so what is all this about? Here's what it's about. In order for most drugs to get through that cell membrane, to cross membranes, to diffuse through membranes, they have to be in a form that's fat soluble. Because if it's a water-soluble form of the drug, it can't get through this middle fatty area. Drugs are too big to go through these pores or channels. They're too big to go through ion channels. And most drugs are not going to be transported by transporter proteins. There are transporter proteins or carrier proteins that are designed to transport sugars into the cell and transport amino acids, but drugs are not designed to be picked up and carried into a cell or across a cell membrane by a transporter protein. So if a drug is going to diffuse across membranes of the body, it's got to be fat soluble. Okay, now that we pointed that out, so under pharmacokinetics on page B1, so what is absorption? It is the transfer of the drug from the site of administration across membranes, and we mean cell membranes, into the bloodstream. Cell membranes are fatty in nature. Now, there are three major factors that affect the rate. That means how quickly that drug can be absorbed or move across these membranes. The first factor that affects the rate, how quickly it gets across the membranes into the bloodstream, is the route of administration. We've already learned if you inject it into the bloodstream, it's immediately in the bloodstream. It didn't have to be absorbed. You put it there, right into the bloodstream. If you swallow it, it's got to be absorbed across the wall of the stomach or across the wall of the intestine. It's got to get across those membranes, cell membranes of the wall of the alimentary canal. If it's going across, if you put it in the rectum, it's got to be absorbed across the wall, all those cells and cell membranes that form the wall of the rectum. So the route of administration. The second factor is dosage. The word dosage is the same as the word concentration. When you took courses like in chemistry and physiology, they talked about concentration. As you increase the concentration of a chemical, the rate of diffusion speeds up. Right? Increasing concentration increases the rate of diffusion. The word that means the same as concentration is dosage. If you give 10 milligrams, or you give 25 milligrams, or you give 100 milligrams, you're increasing the dose or the concentration, which increases the rate of diffusion. The rate of diffusion. The higher the dose or concentration, the faster the rate of diffusion. The third factor is the lipid solubility. We said that in general, in order for a drug to move across membranes, that middle part of every membrane is fat. And it's got to be fat soluble to get across those fatty membranes. Okay, so those are the three factors. And then we have to add one more complicating thing. I wrote right here, most drugs are either weak organic acids or weak organic bases. First off, what do I mean by organic? Most drugs are hydrocarbon molecules, organic molecules. Think of aspirin. Aspirin is an organic molecule. Lidocaine is an organic molecule. Vitamins are organic molecules. So most drugs are organic molecules. And these organic molecules, most drugs are either weak organic acids or weak organic bases. What's an example of a drug that's a weak organic acid that you would know? Aspirin. Who remembers what's the chemical name for aspirin? Remember, it's abbreviated ASA? Acetyl salicylic acid. Aspirin is an organic acid, a weak organic acid. What's vitamin C? Anybody know the chemical name for vitamin C? Ascorbic acid. So there are many drugs that are weak organic acids. What's an example of a drug that's a weak organic base? Codeine. In fact, almost any chemical that ends in -ine, INE is a weak organic base. So let's talk about a weak organic acid first. All right, so what I'm going to do right now is I'm going to give you a little bit of detail, and then I will tell you the bottom line. And I know that really at this point, most of us just say, you know, Professor Fink, I just don't keep it simple. Just tell me what do I have to know. I'm going to give you the background, then I'll tell you exactly what you have to know. Okay, I want to remind you, you've all had chemistry. All right, this is commonly the way we represent a weak organic acid. Okay, the A stands for the chemical, and it has a hydrogen on it. And it can disassociate. So here's this chemical, and it disassociates or ionizes. And what is the definition of an acid? A chemical that when it disassociates, releases hydrogen ions. So HA becomes an H, the hydrogen ion, and an A with a minus. Does everybody follow what I just did? So in the case of aspirin, aspirin is acetyl salicylic acid, right? So why is it called an acid? Because it can disassociate, releasing a hydrogen ion, and the rest of the molecule is called acetyl salicylate. Okay, this is what acids do. Right? They disassociate. They release a hydrogen ion. This is the form of the drug that is in the ionized form. You say, what do you mean? Well, it's got an electric charge. It's ionized. Drugs that are ionized are water soluble. Now, why are they water soluble? You may remember vaguely that water is a polar solvent, and molecules that have an electrical charge easily dissolve in water. For example, salt dissolves in water, forming sodium ions and chloride ions, and they easily dissolve in water. Okay? Now, this is the non-ionized form of the drug. The non-ionized form is the lipid-soluble form, the form that can dissolve in fats. The non-polar form, the non-ionized or non-polar form. So, aspirin can appear in two forms. It can be in the non-ionized lipid-soluble form or the ionized water-soluble form. Does everybody follow that? Because it can undergo dissociation. Now this is reversible. This can go this way, it can go this way. And one of the things that affects the direction it goes in is, remember something called a mass action equilibrium? If you increase the amount of this, it drives the reaction this way. If you increase the amount of either hydrogen ion or this form of the drug, it drives the reaction this way. Let's focus our attention on hydrogen ion. If we increase the amount of hydrogen ion such that there's a lot of hydrogen ions, then they're going to tend to combine with the acetyl salicylate so that almost all of the acetyl salate will have hydrogen ions attached to it. If we reduce the amount of hydrogen ions, so in other words, increasing hydrogen drives the reaction this way. If we reduce the amount of hydrogen ions, then there will be a lot of this form of the drug that won't have hydrogens attached. It'll be in this form. So changing the acidity will affect whether increasing the amount of hydrogen ions or acidity will make most of the drug be in this form. Reducing the acidity will make most of the drug in this form. You'd say, why do we care? Because the form of the drug that will cross membranes is this form. This form has difficulty crossing membranes because it's in the water-soluble polar form, ionized form. This is in the non-ionized, non-polar, lipid-soluble form. All right, now at this point, I'm probably driving you crazy. So let's try to make this relevant to something. Let's look on page B3. Okay, on B3, at the top. So imagine you swallowed aspirin. You swallowed aspirin, and you know that aspirin can be in two forms, acetyl salicylic acid or acetyl salicylate. Now, We said the form that it's in depends upon, in part, the pH, the acidity. What do we know about your stomach? It's got a lot of acid in it. And where there's a lot of acid, we said that when there's a lot of hydrogen ion, the hydrogen ion will combine with the acetylsalicylate, so most of the aspirin will be in this form, which is the non-ionized lipid-soluble form. So, in the stomach, weak acids like aspirin are in the non-ionized lipid-soluble form that is rapidly absorbed across the stomach. On the other hand, in the intestine, where the acidity is less, weak acids like aspirin are poorly absorbed. So the point of this picture is that, and here's part of the bottom line, weak acids are absorbed across your stomach, but they are poorly absorbed across the intestine because of the acidity. In the stomach, where you got a lot of hydrogen ion, most of the aspirin will be in the non-ionized form. So, we had mentioned earlier that the problem with aspirin is rapidly absorbed across the stomach, but it irritates the stomach. So we said they created that ecotrin, that enteric capsule-covered aspirin, so that prevents it from being absorbed in the stomach. So then the aspirin goes to the intestine. Here's the problem with ecotrin. Most of the aspirin in the intestine is going to be in the ionized water-soluble form, which has trouble getting across the wall of the alimentary canal, so it's poorly absorbed. So the problem is weak organic acids are primarily absorbed across the stomach. Now for a base, it's just the reverse. Back on page B1. Back on page B1. So it says weak organic bases. Now, we're going to represent most organic bases. What makes them basic is they have an amino group. An amino group. An amino group, remember an amino acid is an NH2? Now, if we have a weak organic base, such as codeine, codeine has an amino group. Another chemical you know that has an NH2, NH type of group, amide local anesthetics. Amide local anesthetics. All the amide local anesthetics are weak organic bases. So here's why they're bases. Since they have an NH or an NH2, a hydrogen ion can attach to it, making it NH3+. So it can gain a hydrogen. An amino group can gain a hydrogen, making it ionized. So a weak organic base can be either in this form, or if it gains a hydrogen, it can be in this ionized form. Which form, if it's in the ionized form, that's the water-soluble form. That's the form that has difficulty getting across membranes. If it's in the non-ionized form, that's the lipid-soluble form. That's the form that easily gets across membranes. So whether the drug is in this form or this form depends upon the acidity. When you increase the acidity, most of a weak organic base will be in the ionized form. If you reduce the acidity, most of the drug will be in the non-ionized form. Again, looking at page B3. So look right here on B3. It shows a weak organic base, such as codeine. Let's imagine somebody swallows codeine. So can everybody see the way they drew it? They show that the base can't get across the wall of the stomach. Can everybody see it? Hit the wall of the stomach and it bounced back. It can't get across the membranes. Because where there's a lot of hydrogen ions, most of the weak organic base of codeine will be in the ionized water-soluble form. But in the intestine, where there's a low amount of hydrogen, most of the weak organic base of codeine will be in the non-ionized lipid-soluble form that's easily absorbed. Now, I've tried to explain what's going on. Let's say that you understand it. Fantastic. let's say you're thinking, I don't understand it, I don't even know what you've been talking about for the last 5 minutes. Then here's the bottom line that I want you to know. This is the bottom line. Weak organic acids are absorbed across the stomach. Weak organic bases are absorbed across the intestine. That's what I want you to know. I've tried to explain why that is, because whether they're in the ionized or non-ionized form is affected by the acidity or pH. So aspirin is absorbed best across the stomach, but it irritates the stomach in the process. Weak organic bases cannot be absorbed across the stomach because in the stomach, where there's a lot of hydrogen, most of the weak organic base will be in the ionized form that cannot get across the membranes. But in the intestine, where the pH is higher, meaning there's less hydrogen ion, most of the weak organic base will be in the non-ionized lipid-soluble form that makes it easy to get across the membrane. Okay, so let me finish off with this to help you understand what the hell I've just been talking about. Let me make it relevant. You have learned that when you're giving your lidocaine, you should not inject into an inflamed area. Why?
It's more acidic.
It's more acidic. So what? It doesn't work. Why? Because we just learned that weak organic bases only get across membranes in a basic environment, not in an acidic environment. You're starting to see the connection. When the lidocaine, which is a weak organic base, is in a highly acidic environment, it's all going to be in this ionized form that can't get across the membranes. It's not going to work. So you don't inject it into the inflamed area. So where are weak organic bases best absorbed? Where it's not high in acidity. Where are weak organic acids best absorbed? Where there is a high acidity. These are just the opposite. So if you're asking me where's the best environment for aspirin to be absorbed, in the stomach, where it's acidic. If you ask me where's the best environment for lidocaine or codeine to be absorbed, in an environment where it's not acidic, where it's alkaline. That just has to do with this. That's the connection. There's a picture on page B2, at the bottom of B2. This is the distribution of a drug. So first, how is a drug absorbed into the bloodstream? If you swallow it orally, it's absorbed from the stomach or intestine, the gut, and where's the first place it's carried to? The liver, by the hepatic portal vein. The problem with that then, when you take a drug orally, is the liver is where most drugs are broken down. So that's a big negative. That's a disadvantage in taking something orally, because the very first place it's carried to is the liver by the hepatic portal vein, where it starts to break down the drug. So not only do we not know how much is being absorbed, we don't know how much is going to get through the liver. Okay, now what if you gave the drug intravenously? You injected it right into the bloodstream. If you inject it right into the bloodstream, this box right here represents the bloodstream. It says plasma. I wrote bloodstream. This is the bloodstream. So if you inject it intravenously, it is in the bloodstream. Here, it had to get into the bloodstream. What if you give it intramuscularly? You'd say, what do you mean? Okay, so you gave a shot. Has anybody ever gotten an antibiotic like penicillin in the butt?
I've gotten a shot.
This is where you got it when you were a kid, right? So they put it in the gluteus medius muscle, intramuscular injection. All right? Anybody ever had a shot in your deltoid muscle? Okay, so these are intramuscular. So when they're intramuscular, they have to be absorbed into the bloodstream. Into the bloodstream. Once they're in the bloodstream, so we've got the free drug, we also have some of the drug that binds to plasma proteins. Some of the drug is going to bind to proteins in the blood. And then there's also the metabolized form of the drug. This is called metabolites. You'd say, what do you mean metabolized form of the drug? And when drugs go to the liver alters them into a metabolized form that's also circulating in the bloodstream. So we're going to have more to say about where drugs go in the body. So on page B5, what is the distribution of a drug? What does that mean? And I wrote, that's the movement of the drug through the body. So once it's been absorbed into the bloodstream, then it's going to be carried everywhere in the bloodstream. It's going to be distributed throughout the body. Now, as it's being carried in the bloodstream, the drug will start to leave the bloodstream and attach to different locations in the body, in the tissue. Now, when it attaches, when the drug leaves the bloodstream and attaches to active sites where it is going to exert an effect, those are called sites of action or receptor sites. So, what's an example? When you take a narcotic drug like codeine, right, you swallow it. It's absorbed into your bloodstream. It's carried everywhere in your body, in your bloodstream, but the active site, the site where codeine works, is it binds to endorphin receptor sites on neurons in your brain. You ever heard of endorphin receptor sites? Mm-hmm. When you take an antihistamine, right, for like Claritin or Allegra, so you swallow it, it's absorbed into your bloodstream, it's carried everywhere, and it starts to bind to histamine receptor sites. And by blocking histamine receptor sites, that's how antihistamines work. So the vast majority of drugs act on these receptor sites on cells. Now, it's also possible, in fact, many drugs will also attach to other sites where it doesn't have any effect. It doesn't create any action. But nevertheless, it attaches to these inactive sites. These are known as acceptor sites, or inactive sites. So I wrote, for example, that Valium, and in fact, most psychoactive drugs, most drugs that affect our brain, their site of action is in the brain, but they also tend to accumulate in fat cells, in fatty tissues. Now, there's a reason for this, and I'll explain the reason. It has to do with something called the blood-brain barrier. Anybody remember ever learning about the blood-brain barrier? So the blood-brain barrier is the, well, let's show you a picture. On the previous page, B4. So here on the top left, it shows a picture of two capillaries, two little blood vessels. Most capillaries in our body, the capillaries are the smallest blood vessels. They have a very thin wall that's just one cell layer thick. It's simple squamous epithelium. All right, one cell layer thick. So it's pretty easy for most drugs moving through the bloodstream to diffuse across this very thin wall formed by one layer of cells that make up the wall of the capillary. However, the capillaries in our central nervous system, the capillaries in our brain and central nervous system, not only have a capillary wall of simple squamous epithelium, but they have another layer of cells wrapped around the capillary wall, and this layer of cells are called astrocytes. Now, I don't care so much that you remember that. You probably learned it, but that's not our point here. But there's an additional layer of cells. So the capillaries in the central nervous system don't have one layer of cell, like most capillaries in our body. They have two layers of cells. So we have learned that a cell, the cell membrane, is mostly fat, right? Phospholipids. So in order for a drug to get across this double layer of cells or double layer of cell membranes, it has to be very fat soluble. Drugs that are not very fat soluble, they may be able to get across one layer of cell membranes, but they're really not going to be able to get across two layers of cell membranes unless they're very fat soluble, because a cell membrane is fatty in nature. So Any drug that can get across this blood-brain barrier, this is this extra barrier that exists between the bloodstream and the brain cells, any drug that can get across this double layer of membranes is very fat soluble and tends to accumulate in the fat cells. Now, let me put this in a context that I'm going to give you two examples of what we're talking about. One of the side effects of most antihistamines, one of the common side effects of most antihistamines is they make you drowsy. Okay, they cause sedation. They make you really sleepy. So have you ever taken an antihistamine and it made you sleepy? So in fact, this is a problem because sometimes you got a runny nose. Let's say you've got to do some cleaning, scaling of teeth. You got to have something to stop your nose from running, and yet it really makes you sleepy. It's really hard to function when you can barely keep your eyes open. And antihistamines are drugs that are very lipid soluble. And because they're very fat soluble, they cross the blood-brain barrier and affect your brain. They make you sleepy. Now, you want them to work on your nose. You don't want them to work on your brain, but they happen to get across the blood-brain barrier very quickly. So, they created newer antihistamines. The newer prescription antihistamines like Allegra and Clarinex claimed that they cause less sedation, less drowsiness. They made them purposely, they made them less fat soluble. By making them less fat soluble, they're less able to cross the blood-brain barrier, and therefore, if they have more trouble getting across this double layer of cells that's found in our central nervous system, they will cause less effect on the brain, including sedation or drowsiness. So that's why this was one of the earlier ads to one of these newer generation antihistamines. And the ad said, which was targeted at doctors, for these new antihistamines, the blood-brain barrier may be the key to separating unwanted central nervous system effects from desired therapeutic actions. If the drug has trouble getting across the blood-brain barrier, then it can still stop your nose from running, but it has trouble getting across the blood-brain barrier and affecting your brain and causing sedation. So the point is, most drugs that are able to easily go to the brain are very fat soluble because they've got to be able to get across that blood-brain barrier, so they accumulate in fat tissues. So a long time ago, before any of you were born, in the 1970s, in my generation, a lot of people were taking hallucinogenic drugs, right? Going on trips, right? So they found that instead of getting on a plane, they took a drug trip. So the effect, obviously the site of action of hallucinogens is the brain. That's where it's affecting. But we said that any drug that can easily affect the brain is very fat soluble in order to get into the brain, so it tends to accumulate in fat tissue. So as a result, that drug, even when its effects stopped working on the brain, it was still in the fat cells. So that's why the person could have what were called flashbacks. Because the drug was still in their body, it could go, especially if they started losing weight and shrinking their fat cells, some of that drug that was in the fat cells would go back into the bloodstream and affect their brain again, and that was called a flashback. That's what was causing it. Now, an example of what we're saying is shown in this graph. So this graph is showing what happens after an intravenous injection of a barbiturate sedative called thiopental was injected into somebody. Now, thiopental is a sedative, a barbiturate sedative, so they injected it into the bloodstream. So you'll notice that right here at the very beginning, where is the drug? It's in the bloodstream. Does everybody see that? Mm-hmm. Now, it's circulating in the bloodstream. It's very fat soluble. It diffuses out of the bloodstream, and where does it start to go to next? As it leaves the bloodstream, where is it entering? The brain. And so when it's in the brain, which is its site of action, it's going to cause drowsiness. But then what happens is it eventually starts to go to the fat tissue because it's very fat soluble. Now, when the drug, this sedative, is in your fat cells, it doesn't have any effect on your fat cells. That's an inactive site. But the main point that I'm trying to make is this. Even though the effect of the drug has ended, once it goes out of your brain, it stops having causing sedation or making you drowsy, but the drug is still in the body. It is in the fat cells. So the point here is that sometimes after you take a medicine, even after the effect ends, that doesn't mean the drug isn't still in your body. It may still be in your body, but it may have redistributed to a different part of your body. Now, I'm going to give you a couple of other examples of what I'm talking about as well. What I just described on page B5 is called the redistribution of drugs through the body. So I wrote that the action of some drugs is terminated not by its elimination from the body, but by its movement or redistribution to another site in the body, such as when it redistributes to fat tissue. The drug is still in your body, it's just that its effect is no longer present. It's no longer exerting its primary action, because it's redistributed to a different place. Let's come back up here to inactive sites. So we were talking about active sites and inactive sites. Consider the following. Let's consider tetracycline. Now, tetracycline is what kind of drug? What's it? It's an antibiotic, right? So you give tetracycline, and a version of tetracycline you're very familiar with, I think, is Arestin for periodontal infections. All right? Now, you're pretty much applying it topically, but some of it will be absorbed systemically into the bloodstream. But you know that tetracycline tends to accumulate in tissues containing calcium, such as bone tissue and teeth. So you know that tetracycline, in fact, is contraindicated in children who have growing and developing bones and teeth. It's also contraindicated in pregnant women because it will accumulate in the developing bones and teeth of the fetus. So the site of action of tetracycline is the bacteria, but it also tends to attach to bone tissue and teeth, the tissue in teeth. That's an inactive site, an acceptor site. It's not doing anything in bone tissue, but it does accumulate there. So there's a number of drugs where they may be acting in one place in the body, that's their site of action, but they may accumulate in other places in the body where they don't have an action, but they're nevertheless still there. All right, does everybody follow that? So there are what we call receptor sites. Those are where the drug attaches and exerts an effect. And there are acceptor sites, where the drug simply accumulates but doesn't have an effect on that part of the body. Let's return to this diagram that we showed you previously, this one right here. As the drug is carried in the bloodstream, some of it is going to go out of the bloodstream and activate receptor sites. Sites of action. That's where the drug exerts its effect. If it's a Valium, its site of action is the brain. If it's an antihistamine, its site of action is where there's inflammation. If it's an antibiotic, its site of action is where there's bacteria, wherever it's acting. So let's just complete this. This also shows that, of course, as these drugs that are in the bloodstream, we know your kidneys filter the blood. Your kidneys filter the blood, and they form urine. They form urine. And some of the drug, as the kidneys filter the blood, some of the free drug will be excreted in the urine, as well as the metabolized form of the drug will be excreted in the urine. So this diagram is simply kind of summarizing what happens as you take a drug. The drug, whether you swallowed it or gave it intravenously right into the bloodstream or intramuscularly, it eventually enters the bloodstream. Some of it is in the active form, some of it is attached to proteins in the blood, and some of it has already been metabolized or inactivated by the liver, and it's in this metabolized form. Your kidneys filter the blood, and as they filter the blood, some of the free drug or active form will come out in your urine, as well as the metabolized form of the drug will come out in the urine. So this analysis of where drugs are going in your body is called the distribution of the drug through the body.